Thank you for participating in this webinar hosted by BHI on audit guidelines for the provider. My name is Bonnie Wright. I have my MBA in Healthcare Administration, and I am the Provider Quality Monitoring Specialist here at BHI. As a provider, you will be subject to audits by BHI. These audits will consist of quality of documentation, compliance of services, which is a claims validation, as well as an on-site review. The following slides will discuss the quality portion of the audits as well as the on-site review. When I review the quality portion of the record, I'm looking at 5 different areas: the administrative information, intake assessment, service plan or treatment plan, progress note, and discharge. The following slides will go through each of these in more detail. As far as the administrative information is concerned, I'm looking at basic member demographics, so member name, date of birth, Medicaid ID number. I'm also looking for emergency contact. And in addition to that, I'm looking for some consent, such as consent for services, the professional disclosure statement, if it's somebody who is 18 or older, acknowledgement of advanced directives. Also looking for things like medications, and if they're not taking medications, to clearly document none reported or not applicable. I'm also looking for clients' rights and responsibilities to be documented, as well as notification of BHI grievance and appeal rights. And lastly, for this section, I'm looking for CCARs, an admission CCAR, an annual CCAR if they've been within your program for 1 year or more. If your program has various levels of care and the member has changed levels of care, we would also look to see for a CCAR for that change of level of care. And lastly, if the member has been discharged, a discharge CCAR. As far as intake assessment is concerned, we're looking for quite a bit of information. We'll start with chief complainant history. First, you want to gather information to tell you what the chief complaint or presenting problem is. So this would be the member is coming to you for depression, and then you want to identify the history and duration of that problem. So the member is coming to see you for depression, which has been ongoing for 6 years or since 2015. You also want to be sure to document the referral source. How did they get to you? Did they find you online? Did their primary care refer them to you? Did a friend refer them to you? You also want to be sure to document their psychosocial history. This would include things such as interpersonal or family relationships, legal history, military history if they're 18 or older, cultural and linguistic factors, any involvement with human services, and for any kiddos 18 or under the age of 18, custody arrangements and or prenatal and perinatal events. If it's a kiddo who has been adopted or is in foster care and the individual does not know of any prenatal and or perinatal events, you can just put unknown. You also want to gather a brief medical history. This would include things like current and or past medical history. Allergies should be documented, and if they do not have any allergies, just put none reported. You also want to gather a release of information for primary care physician. If they don't have a primary care physician, you want to look at referring them to a PCP and acknowledging that on the release of information. The last thing is, if you notice any other issues such as dental, vision, developmental disabilities, you would want to request for EPSDT, which we will talk about on the succeeding slides. EPSDT screening is required of all BHI contracted providers. The purpose of EPSDT is to ensure that all members 20 years and younger receive preventive services, which may include dental, mental health, developmental, and specialty services. What does EPSDT stand for? Early, periodic, screening, diagnostic, treatment. It is designed to assess for problems early on, conduct these assessments periodically, screen for potential problems such as mental health, physical, dental, etc., perform diagnostic testing and follow-up if a member is noted to be at risk and treat directly, or refer to an appropriate provider who can provide adequate treatment. These screening services include comprehensive health and developmental history as well as health education. You should only conduct screenings that are within your scope of practice. If you have identified a potential area of need for the member that is outside of your scope of practice, you should refer them to an appropriate provider who can follow through on these needs. EPSDT services are covered under Medicaid. When medically necessary needs are not covered, either the member or the provider can contact BHI Member Services Line for additional resources. You or the member may also contact the Client and Clinical Care Office at HCPF to assist with the referral. Please feel free to go to the link within this slide to find out more information regarding EPSDT. You want to be sure to document a member's mental status exam. This includes things such as presentation, appearance, speech, memory, judgment and insight, intellectual functioning, thought processes, attention concentration, mood and affect. Medicaid is now requiring that a developmental disability screening is conducted. There are 4 primary areas that should be assessed, which include things like ability to use community resources, communicate appropriately, plan and organize time, and engage in daily living functions. The daily living functions could include things like being able to shower on their own or brush their teeth without someone having to remind them. You also want to be sure to collect a brief substance abuse history, which includes any current and or past substance use, as well as previous treatment episodes and or responses to those episodes. If the member reports no substance use history, for this section you would just note none reported. You also want to gather safety and risk assessment, which includes assessing for suicide risk, such as suicidal ideation, thoughts, and or plan. Also a violence risk assessment. This can include things such as homicidal thoughts, ideation, or plan, as well as any history of violent tendencies. Lastly, for this section, you want to document a crisis plan if they are experiencing any suicide or violence risks. If they do not have any suicide or violence risks, you need to indicate that no crisis plan is needed. Last thing for the intake assessment is to note DSM-5 diagnoses using ICD-10 codes. As far as service plans are concerned, you need to ensure that there is a current service plan present. A service plan is to be updated every 6 months. It needs to be consistent with the diagnosis, and if for some reason the diagnosis has changed, document when and why that change occurred within the service plan. Also, please be sure to include the member's strengths within your service plan and ensure that the goals are written in the member's language. As far as goals and objectives are concerned, you need to be sure that they are individualized. They should be positive and non-judgmental and focused on the growth and development of new skills throughout the process of treatment. And they should also be specific and measurable. So if you have an objective that is something like the member would like to reduce anxiety, you need to identify ways in which you're going to measure progress on that objective. The way to make that concrete and measurable is to say, member will identify 3 instances that cause anxiety and 3 ways in which they can overcome anxiety by January 1st, 2017. Also be sure to include any clinical interventions that you're going to use throughout the course of your therapy, such as CBT, DBT, motivational interviewing, etc., as well as the frequency in which you're going to meet with the member. You might meet with them 3 times weekly. You may determine that they need to be met with twice weekly, once weekly, maybe twice a month. Be sure that all services that you will be providing them with are included on the service plan, such as individual therapy, family therapy, etc. Lastly, you need to be sure that all signatures are present on the service plan. This would include the member or guardian signature. Any member who is 14 years of age or younger requires a guardian signature, and it also needs to be signed by the clinician. If you work in an agency that has psychiatric services and the member is receiving services from that psychiatrist within the agency, you would also want to attempt to get the psychiatric signature. However, if the member is receiving any services outside of your practice which could include medication management, you are not required to obtain the signature of that physician. A progress note should include the goal that you are working on throughout the course of that session and should relate directly to the treatment plan. It should also include the progress that the member made on that goal and/or the lack of progress that the client has made. You also need to include the intervention that you are using throughout the course of the session to help support the member in making progress, as well as how the member responded to that intervention. Lastly, you want to be sure to identify a plan for the next session, which could be as simple as, we'll meet with member in 1 week, or we'll meet with member in 1 week and member will identify 3 ways in which to reduce anxiety. The discharge summary should include a summary of services. This can be very brief, something like individual services, family therapy, etc. Any services that you provided to the member. It should also include the reason for discharge. That could be anything from the member was referred to a higher level of care or the member has completed treatment. You also want to include a summary of the member's response to progress to treatment. You do not need to detail out every single thing that the member did throughout the course of therapy, just a summary such as member made great progress in identifying instances of anxiety and identifying coping skills to help reduce anxiety. Lastly, you need to include any referrals or follow-up as needed. In the case of a member who you may have referred to a higher level of care, you want to identify who that referral source was and any follow-up that you may have conducted if it was necessary. You also want to ensure that you are signing the discharge summary with your name, your credentials, and the date in which you sign that summary. The purpose of the on-site review is to ensure that the physical space you are providing services in is a warm and welcoming environment, as well as ADA compliant. There should not be any PHI laying out, holes in the walls, or wires hanging out of the ceiling. There are also a few access to care questions that will be asked, such as routine appointment availability, urgent appointment availability, and emergency services. For any organizational providers, there will also be several policies that will be reviewed. If you have any questions, please feel free to contact me either via email or telephone number. My email is bwright@bhicares.org, and my telephone number is 303-361-8165.
This is clinical documentation training for routine outpatient services. My name is Ann Doring. I'm the compliance monitoring specialist here at BHI. The information in this presentation is intended to assist providers in compliance with Colorado and CMS standards. Other BHOs may bill and interpret requirements differently. Therefore, the information provided is specific to BHI. BHI is currently collaborating with other BHOs for uniformity to eliminate need to know client's payer when documenting records. BHI recommends that you always use the most current Uniform Service Coding Standards manual, as guidelines may change from one update to the next. The USCS manual contains guidelines for CPT and HCPCS codes. If a CPT code or HCPCS code you are looking for is not in the manual, it is not funded by Colorado Medicaid. The coding committee consists of members from each BHO, HCPF, OBH, along with mental health centers. If you have a question regarding anything in the current manual, you can ask me. If I do not have the answer, the question is taken to the committee for discussion and consensus. The manual is updated at a minimum annually. The current manual can be found on BHI's website, bhicares.org. OBH and HCPF websites also. At least you should be familiar with the codes for services you are rendering. Each code has individualized descriptions and documentation requirements. During the audit process, this manual is the standard for compliance. Each code in the USCS manual has a dedicated page that outlines the description of the code, allowable populations, mode of delivery, staff requirements, and place of service. Technical documentation requirements and service content requirements are detailed. This documentation is the minimum required. Note that many codes have minimum and maximum durations. Information on units calculation is also indicated. The technical documentation requirements are to be included in all documentation for treatment services such as assessments, treatment planning, progress notes, and case management. The requirements include date of service, when was the service rendered, duration of service. This is the start and end times with the client. This information is necessary in some cases, such as for timed psychotherapy codes. It is used to calculate total duration for code selection. Without this information, correct code selection cannot be validated when under review. Duration is also required for correct selection of 15-minute and 1-hour unit calculation. Refer to individual code page for how units are to be calculated. Place of service is the location where the provider is rendering service. For mode of delivery, was service rendered face-to-face, telephone? Again, refer to individual code page for allowable modes for code you are documented, as they can vary between services. The clinician's signature is required with credential and date. A supervisory staff is required to co-sign if clinician rendering service does not meet the minimum requirements. See the individual code page for staff requirements for rendering service. A separate progress note is required for each service. As example, a session of family therapy is followed by a session of individual therapy for the same client. A separate note for each discrete service meeting all documentation standards is required. That's kind of choppy. Service content requirements vary by code, so again, refer to code page for specific requirements. Reason for visit. What was the intended goal or agenda? This should relate to the treatment plan. Description of services. This is the content of the session. This does not need to be lengthy. The content just needs to meet the minimum requirements. This is your documentation, therefore include as much information as you like. Therapeutic interventions and client response. This requirement is often left out of documentation. As a clinician, what interventions did you use during this particular session, CBT, DBT, etc.? And how did the client respond to those interventions? Progress toward treatment goals. The note needs to document where the client is in reaching one or more of the goals on their treatment plan. Clients do not always make progress. Document any regression if applicable. The plan for next contact is simply what happens after this session. Are they scheduled to meet next week? Are they going to contact their PCP? Maybe they're going to do some journaling. The code for billing a behavioral health assessment is 90791. Collaterals can contribute in collecting information for the assessment. The client must be present at some point during the session, as a mental status exam is required documentation. The service can be rendered face-to-face and by video conference. Phone is not an allowable mode of delivery. As this code is billed by encounter, you can only bill once for completing the assessment. Assessments should be updated at a minimum every 6 months. A dated diagnosis is required in the member record. At a minimum, this should be updated annually. The diagnosis in the record needs to match what is documented on the claim. ICD-10 is required documentation on the claim. Therefore, the diagnosis in the record also needs to be documented in ICD-10 format. The description alone is not suffice. You may have seen in Medicaid standards that the requirement for updating treatment plans is annually. OBH has a more strict requirement to update every 6 months. BHI follows OBH guidelines. Treatment plans are to be completed prior to any therapeutic services being rendered. The only exceptions are outreach services, screening services, assessments, and crisis services. A brief initial treatment plan can be developed and used for the first 30 days until a more detailed treatment plan can be completed. In most circumstances, the general order is 1. Complete an assessment, 2. Develop the treatment plan, and then 3. Begin therapeutic services. Specific to BHI, treatment plans are paid under the time-based psychotherapy codes 90832, 90834, and 90837. These codes are based on duration of service. 90832, referred to as the 30-minute code, has minimum duration of 16 minutes while the maximum is 37 minutes. 90834, the 45-minute code, has duration between 38 minutes and 52 minutes. 90837 is the 60-minute code. This code is used for psychotherapy sessions 53 minutes or greater. There is no maximum duration to this code. You cannot bill 2 timed codes to meet your total duration for the session. As example, if your session is 1 hour and 25 minutes, you cannot bill 90832 and 90837. Did you catch where I started over? This is an example of BHI's template for treatment planning. It is available on BHI's website at bhicares.org. You can request the form as a Word document. If you use this form correctly, you should meet the minimum requirements for treatment planning. Note that the same technical documentation requirements for other documentation applies to treatment planning, and the service content required is specific to treatment planning. As previously mentioned with treatment planning, use these codes to bill for individual therapy. Be aware of the minimum and maximum durations for each code, as these services are billed as encounters based on time. These sessions can be face-to-face and via video conference with the client. They cannot occur over the phone. The treatment plan is to be dated within 6 months of the date of service. Code H0004 gives flexibility in terms of time increments, place of service, and mode of delivery. As example, you are scheduled to meet with the client at 10 a.m. It has snowed overnight, and the client does not want to get out on the snowy roads. You can render this service over the phone. Another example, the client has received some unexpected news. Their anxiety is high. They want to talk to you to work through their anxiety. You spend 10 to 20 minutes on the phone with them. By the end of the conversation, they are feeling better. Note that the same technical documentation and service content requirements apply. This table is used as reference for all 15-minute unit codes. This will guide you to the appropriate calculation of units based on the duration of service rendered. As an example, you spend 1 hour and 10 minutes on a service. The appropriate number of units to bill is 5. This is an example of a progress note for individual therapy using DAP format. You can arrange your document how best it makes sense to you. If the documentation is there when the record is under review, we will find the information. BHI has developed a template for progress notes. Again, it is available at bhicares.org. You can request the Word version if you would like to modify, such as remove BHI logo and add your own, or rearrange where the documentation is in the report. Note that all technical documentation and service content requirements are there. There are 2 codes for family therapy. 90846 is a code for family therapy without the client present. The focus of the session is on family dynamics relating to the client's condition. 90847 is a code for family therapy where the client is present. Again, the focus of the session is on family dynamics. The focus is what distinguishes 90847 from individual therapy with family or collaterals present. Here is another progress note, this time for family therapy. Again, All requirements are documented and the location of information is at the writer's discretion. Group therapy codes are selected based on the client's diagnosis. H0005 is specific to primary SEG diagnoses. This code requires pre-authorization. 90853 is dedicated to primary mental health diagnoses. This code is specific to therapy, not education. As example, this code does not pay for DUI education, whether it is court mandated or not. Document the number of attendees. No more than 12 attendees are allowed per group session, while less than 2 attendees is not considered a group. In that instance, another code would be appropriate, as it has turned into a one-on-one session. Generally speaking, the reason for visit and description of services will be the same for all clients. This information can be copied to all attendees' progress notes for the date of service. The other service content requirements need to be individualized as response to intervention, progress, if any, and plan for next contact will be specific to individual client. The unit and duration for these codes are different from each other. Refer to individual code pages in the USCS manual for unit and duration specific requirements. Again, technical documentation and service content requirements apply. For H0005, refer to this table to calculate units. You can find this located in the USCS manual. Here is another example of a progress note. This one is for a group therapy session. For each attendee, an individual progress note is required in their record. As stated earlier, the reason for the visit and the description of service should be the only documentation copied from one client to another for any particular date of service. It is important to document if a client arrives late or leaves early and adjust their duration accordingly. Specific to H0005, their total duration of attendance may differ from other attendees. Interactive complexity, code 90785, is an add-on code. This code can be billed along with another service, such as individual therapy, when one of 4 communication factors listed below are present on the date of service. As an example, you may have a client that you are treating for anxiety. On a particular session, the client may present with an unusually high level of anxiety where it is complicating delivery of care. A child may have gotten reprimanded before a session and are dysregulated. Document in the progress note the validation for use of the add-on code. Case management is a service designed to assist and support a client to gain access to needed medical, social, educational, and other services. The services include assessing the case management needs. Documentation of the assessment is required. Developing a service plan. This can be a service plan specific to the client's case management needs or can be included in the primary treatment plan. Referring client for services. Document who the client was referred to. Be sure to include minimum service content requirements specific to case management. And finally, documenting the follow-up and monitoring of the referral. The appropriate code selection is determined by the primary diagnosis. If there is a behavioral health diagnosis, select code T1017. If the diagnosis is SED-related, select code H0006. This service is billed in 15-minute increments. Refer to the USCS manual for service content requirements for case management as they differ from requirements for other codes. Here are additional requirements for service content. Here are a few examples of case management. Medicaid has removed many services that were once payable. Here are examples of services you cannot bill for. Here's an example of a case management note using the BHI template for progress notes that I referred to earlier. Again, it is available on our website. The documentation required on other notes are again required on case management notes. The USCS manual has a lot of information. The information presented here is somewhat generalized to get you started in the right direction of documentation compliance. Let us know if you have questions on anything presented or if there is something in the coding manual that you would like clarification on. We are here to help.